Well, I just am so excited that our friends from CDC and NIH and OASH and HRSA and I'm sure I'm leaving somebody out, but everybody, was able to hear this very unusual and inspiring session. So without further ado, I'm going to see that Carmen has her card up.
Thank you so much. That was fantastic. As a person who was born in the previous century, I'm really excited, really excited about learning about all of this is really new to me. And I have several questions for both of you. First one, have you ever done any of this in Spanish? Because I think there's a large market and there's a great need for Spanish-speaking youth to actually access things like this?
Yeah, not yet, but we are starting to see users submit in different languages into our app, and we don't have the capacity at this point, but we are thinking about it.
Well, let me know at some point, because I'd love to have something at some point in Puerto Rico. The other question is out of curiosity with these mystery shoppers. In terms of, I think you mentioned that you have the consent of the clinic or the institution, but what do you do with the data generated, like the patient profile? Like you have the mystery shopper has a data on whatever their data, and how do they erase it, or what do they do with it?
So we actually treat our mystery shoppers as participants, and they consent. They are trained for 4 hours. We debrief after every visit to make sure that they feel safe, that they want to keep doing this. And we've never had a quitter. They actually love it. They find meaning in what they're doing. They feel like, I wish somebody would ask young people about our experience, and I'm glad that now this is getting fed back to the agencies. The sites get an aggregate score, so they don't get individual level data. They hardly ever know who the client was. There is a caveat. There are some instances when we've done technical assistance that we've been going through the qualitative data, and the director of prevention or whomever's in the room with us has said, I remember that day. So I'll give you a good example, because that F grade story that I told you actually has a backstory to it. There were concerns that this particular public health department was going to get their budget cut because they weren't screening enough young MSM of color. And that had been addressed that week at the clinic. And so what the nurses heard from that conversation about funding streams was, whether clinically relevant or not, we need to increase our numbers for this quarter. So everybody is going to get things that are super intrusive, including a penal swab, which is not clinically mandated anymore, right? And when they came back, the director of the agency was sitting next to the nurse practitioner and being like, what did you do? And she said, but you told us that our funding was gonna get cut, so I wanna protect my community. I wanna get those numbers up. So we've just been testing everyone for everything. And so that led to a different conversation, right? And that led us to also have conversations with the health department about how they were pushing their messaging around quotas, right? Careful about the quota, because then people will never come back, and then we're in trouble.
Yeah, thanks for those talks. And I was kind of also thinking of Seth's talk about home kits and things like that, and how to bridge kind of the M-Health and actually having people get kits and stuff. We hear that, young MSM of color, are more likely to have, use their phones, whereas other people use computers and different things. And at the same time, we know there's very little uptake of people, requesting HIV home kits or STI kits. And so I'm wondering, how do we really drive traffic? You mentioned a little bit about how, trying to drive traffic to some of these apps and platforms. And, when the priorities, this is kind of pretty low on their, I don't know if you card sorted, like what are their daily priorities, but I would imagine this is pretty low. And so what are some ways to kind of either raise that priority, or I'm thinking more about the structural stuff. Maybe we can make those priorities less impactful. Like, so we decriminalize first, we, get people food. But do you have any, it's kind of a big question, but do you have any thoughts about that?
Yeah, I can start. I think that the current methods of how to get young people in front of new tech products, a lot of the money and effort is going towards social media marketing, which is incredibly expensive. And chasing down influencers who want to be pictured with your product or paying Facebook essentially to run very targeted ads costs a lot. And so I think that probably my recommendation would be to start small with specific local communities and trying to figure out understanding that group of teens, specifically where they're getting their information from, and then customizing a campaign for that. And then we might, over time, if we do it in New Haven and Raleigh-Durham and El Paso, Texas, see that it's the same thing. But at this point, I think that there isn't a very clear, you should put all of your money in this thing. I think it's a lot of trial and error at the very small level and hopefully building an evidence base for something sooner rather than later.
I would ask Patrick Sullivan that question. So HealthMinder was originally developed by both NIH and CDC funding streams, and it's supposed to be an app where folks can go in and order test kits, both HIV and STIs, and condoms and lube and some other swag, and he continues to monitor how often it's coming out. I think why I bring him up is that HealthMinder actually partners with health departments, and so the kits come from the health department. I think that's a way of leveraging, it's something hip that we're doing, and if it does come positive, then you know where to go. Christian, I know somebody mentioned Christian Grove. I think it was you, Seth, this afternoon on. He has one of the light limited interaction technology epidemiology, and he has a cohort of 6,000 very, very high risk MSM and trans people around the country with 92%, 83% testing rates. No, it's not fully white. It's actually quite diverse in rurality and urbanity. I think the caveat that I'll say as a Latino gay man myself, oh, this is getting recorded. Hi, honey. Is that everybody wants to work with Latino and Black MSM right now, and we are tapped out. And so if I get part of it is a priority, and part of it is also can we just get one message across instead of 10 people inboxing me every day about a new survey or app or feature or test or prep or task? I think we need to, as a community, also start kind of streamlining how we're doing this in a way that gives people a room to breathe.
Couple of questions. Very nice talk, both of you. Thank you so much. Are these apps available to people outside of the study? No. Yes. Because I just looked on Play Store and I couldn't find Real Talk. Is it under some other name?
Yeah, we made a very intentional decision to go with iTunes and the App Store. And so if you have an iPhone, you can get it.
Even though many lower socioeconomic folks use Droids?
So interesting. So we worked in 3 sites, mostly with low resource schools and counties, and the overwhelming majority, 80 to 90% of our students, even in Title I schools, had iPhones.
Okay.
And so for a variety of reasons, but including that one, we chose to go with the iPhone.
Good to know. Thank you so much. Then the other thing is, having just dabbled in this, the one thing I know is that it's it has to be fresh. You have to, so you feel like you're constantly feeding the beast. How do you do that unless you have an enormous amount of money and staff?
Yeah, so the beauty of our Real Talk app is that we are actually not creating any new content, so we're curating it. And so our users generate the content. We have a team, myself and volunteers at UNC, who go through, there's a decision tree of how to select which stories are publishable. And then similarly, we have a database of high quality online sex ed resources that exist. And so there's a pre-selected number of topics on porn or sexting that our volunteers then link with the stories that are related to that. And so I agree. I think that some of the great products out there, including amaze.org, which is a website and YouTube channel, and so it's great, but I think that some of them, these programs and projects feel a lot of pressure to constantly create new content, and that was something that we thought about as when we were designing our app.
Yeah, so Get Connected is a brief intervention. We do the same thing for other kind of longer-term interaction interventions. But we knew that things were changing around PrEP, and so when we built it, we built a admin dashboard in the back end where you can actually change the content. So if the guideline changes, I can go in and make that change without having to like pay the developer, beg, plead, cry, bleed, whichever verb you want to use, to go in and change it. We have the power to do that, but again, that requires some forethought if you're kind of moving in this area.
I'll also add that because we have a search feature, we are also able to monitor what our young people are actually searching. And that also helps us as we collect new stories to direct us, like if we have a lot of stories on STIs or a lot of stories about being rejected, that guides the next iteration of stories that we collect from our users. And so just another aside about the benefits of an mHealth intervention like that.
Yes, thank you so much, both of you, for your very innovative work, especially with young people. You answered part of my question about how you're curating this new information, how you're keeping it going. And Jose, you mentioned machine learning and how that can be employed in the future. So thank you for that, because that was like, how do you keep it fresh? But I guess my question have to do with kind of the evaluation, because you described very nicely the formative work, what went into it, the thinking behind it, the backstories in both of your work, which is really nice, because a lot of people don't think about that when you think about apps and so forth, whereas when we develop interventions face-to-face, that's kind of clear. So thank you for bringing that forward and keep pushing that out, that there's real science behind this. But my question has to do with the evaluation piece, which I think is challenging in many ways, is, how do you go beyond just the process evaluations, user satisfaction, to start looking at so that, downstream we could see impact. So how do you begin to measure impact in a way that, well, CDC will want to fund you more, NIH will continue to fund this, and there'll be more of a way to get this work out in a very meaningful way?
Yeah, so Christina Leos is another colleague of mine on this team, and the two of us are really interested in evaluation. And therefore, we asked our developers to build in the capability for us to switch in and out questions that we could set to pop up in the app for students, and they'd be triggered by events. And so if a user has read 10 stories, and they would get this question that pops up to them, or if they've used it for 2 months, here's the question that we would offer. And so we've started now to systematically collect those data, and so hope to, in the next couple of weeks or months, be able to put forth some of our initial results. But it is challenging because not every student or every user will have the same experience in our app, and that's intentional. We don't want to give them all the same 10 stories the first time that they visit and then funnel them through a program like you might think of other traditional sex ed classroom programs. And so we will need to innovate there and try and think through how to do that meaningfully.
So I'm on the other side of the spectrum. So I do RCTs. It is my bread and butter. And RCTs are really terrible for mHealth. I do them because that's what needs to be done, right? Increasingly, this is my soapbox moment. So imagine if you were Apple and I told you, hey, Apple, guess what? I'm going to launch this Apple Watch for you, but you can't make any changes to it for 5 years. From a commercial standpoint, Apple's going to say, no go. From a consumer standpoint, young people are also kind of saying, when am I getting version 2.0? When am I getting 3.0? And under the current RCT, unless you're doing a smart design or something perhaps more sophisticated that doesn't seem to appeal to our colleagues very often, like a CBIT, the continuing evolving designs, we really are stuck. So I think a place in innovation where we have to be perhaps a little bit more nimble is these alternative randomized designs by which technology can be pushed in systematic, rigorous ways, but that behaves more like the market instead of old school in-person interventions.
Okay, 4 more, and then we call it a day and move to public comment. Willie Prado from the internet.
And from the committee. So I think you've touched on this since he asked it a little bit, but this is a directly asking this question. Given the rapid changing nature of technology, it may be important to focus on key elements of efficacious, effective interventions as opposed to a single effective mHealth intervention, which may become obsolete in several years. What do you think are the core elements and not just mechanisms of action of efficacious, effective mHealth STI interventions or STI or related?
Damn, Willie. I thought you were my friend. I think participatory process, through and through. I mean, we wrote content, and then the app came back, and we're like, who do you think is going to read this? No way, right? I like static images. The app wanted animated images and GIFs and a little bit of humor, which I was like, but this is an intervention. And they're like, right. So I think having the kind of similar to ideation, this idea of like the consumer really front and center and being participatory in that process is crucial. I think we need to move away from the traditional 5-year RO1 to test these interventions. We need to start doing more UG3, UH3 mechanisms where you have to meet a milestone by 2 years, and if not, let's move on. And I think we need to go back to factorial designs. I think we need to know what components of the intervention work, which ones don't. Let's break these mHealth interventions apart, so that then we know what to continue to recommend forward. If a test locator doesn't work, and we know from 50 different interventions that just a test locator is insufficient, then maybe it saves us money when we're writing the intervention to say, either we find an existing API and we link it to the app, or we can spend that money in a feature that actually might have better traction in scientific kind of movement.
Yeah, a few thoughts to add, just also based on your previous comment. The 5-year cycle is very restrictive in ways that like the CDC could fund might look like, instead of having 10 large projects, investing in 50 for that first 2-year period where you have to have a proof of concept and meet those milestones. And then from those 50, then choosing the next group that then moves forward, but tiering it in that way so that you all essentially would then be iterating and then collecting information and then placing bets on things that have been tested. And so I think that that is one thing to consider. And then just soapbox, just evaluation, especially with anything related to tech now or in the future, will cost a lot of money. And so if there are ways to streamline or offer technical assistance across, or offer code that across projects for how you could be creating infrastructure to evaluate, I think would position everybody to learn quicker and for us to turn those valuable resources into bigger impact.
Thank you for the nice presentations. I have a question for both of you about what metric are you using to evaluate for success of the program? And secondly, what about sustainability, which you may have just addressed? And how do you keep up with changes? There are many apps out there, so it's a fluid situation, I'm sure. But mainly I'd like to know what's your metric?
So for Get Connected, we actually measure either first time if you've never tested before, because there are some youth who've never tested before. But we do follow the mandate of at least 2 tests over a 12-month period, and that is the trial outcome, is to see not just a test, but did we actually help you start creating a plan? So that's the kind of the trial outcome. I think we're getting there naturally. So there's this work that I do, and Sean and others have done, called Paradata, which is actually the process data of like every single action in the app gets recorded. And you can transform that as a real data point to see what people are clicking on, how much time they're spending on the site, and if they're navigating the site differently. And in the pilot Get Connected trial, we actually found that racial and ethnic minority youth navigated completely different than non-Hispanic white kids. They had the same outcomes, but they were looking at very different components. And I think we've been pushing that now to kind of, if I'm your reviewer, just know. We really are pushing that I should know that you are carefully measuring what people are doing in real time, because if you start seeing, for instance, that use engagement ends at the 2 hours of use or in the first 30 days of the app and it's a year-long trial, you want to know that now so that you can kind of get people back in and not waste money, time, and your emotional health.
Yeah, and so we couched our entire design process around an access question. And so many of our funders really care about the number of teens that we've reached, and then also the number of LGBTQ teens that we've reached. And so typically we have 30% of our users identify as LGBTQ. And so that is really important for us to maintain that we have a very inclusive online space. And we do track the typical outcomes, and that is ongoing, but we look at knowledge, attitudes, communication skills, and then many of the North Carolina Youth First Behavior Survey items, which are the same as the National Youth First Behavior Survey. So initiation of sex and also some of the mental health items. And so we've realized through our stories that many of our young people talk about relationships and then will mention depression or anxiety. And so we're starting to think through, is there a place for Real Talk to offer a space for people to share their mental health experiences and stories, and we can connect them to resources? If so, we would then start measuring the items related to depression and suicidality.
A quick question. How, for Dr. Chen's work, there's obviously other work going on at UNC and elsewhere about more direct intervention, that is, trying to measure change, a series of changes, using avatars and all this other stuff with Patrick Sullivan, as you mentioned. And then there's the game people at Yale, and I forget the woman's name, who, thanks. How do you link all this together? In other words, these are not kind of independent, you have access now to 14,000 young people who are a little younger than the clients of, or the people, the subjects of Lisa Hightower, but all of it has to somehow fit together in some package. I don't understand how it all gets together into something sensible.
It's a great question. I think that many of us are starting to think about it, including working with LGBTQ centers, especially groups that organize at the national level, and then also looking at nonprofit organizations like Peer Health Exchange that already have impact hundreds and thousands of young people because of their programming. What would it look like if we created a suite of products or aggregated them much like the ed tech space has? Like, what if we made it easy? It was like a one-stop shop, and then from our specific iTunes that's for young people and health, how they could navigate that. And so I think we've started, but it's also great. Like, Jose and I share multiple connections, but it's really hard to find the time and then also to hear about other researchers' great work. And so I think that having funding to convene people in this space often is really helpful and would lead to more shared work and then shared impacts and then shared lessons learned.
Yeah, Mike, you raised a really good question. I mean, we in ITech, and you can talk to Lisa and Patrick about this, we actually forced every protocol team to map out their theories, what their features are, and how they were going to track them in Paradata. So that at the end, we can actually do a pseudo meta-analysis of all the apps and figure out what are the things that they all share, whether it be by feature or by design layout, that would give us an advance instead of reinventing the wheel every single time something new happens.
Do you have a meeting? Do you have a meeting space? Do you meet, you accidentally know each other because you're here. You don't have a space where you meet, like the networks meet. There's no, so you should, a suggestion to you, could apply for an R13. Probably, the NIH should, I'm sure, be glad to help create a space where you could all meet together, like Filene and these other people, that unless there already is a space, it's pretty easy for you to identify them.
We had talked about what was formerly Sex Tech, which is now YTH Youth Tech Health. And so we both realized that we've both been to that conference in various iterations. And I think that there are places it's still really hard to get to. And then also, it's not conducive for nonprofits and other people who are non-academics to get to those conferences because they're usually in San Francisco and it's really expensive. So I think it's great if Jose and I can meet and talk there, but that's a very small sector of everybody who's doing really cool, innovative work. And so I think we need to spend more time thinking about how to convene the broader range of people who are trying to do this work.
So trends in technology use are constantly changing, right? Annually, even monthly. I think mentioning the UGHs and those are, I think you're right on with that. But and that helps to get studies tested faster. But there's another part of that, and that's sharing of results and sharing of data at all, how do we change the research culture to get results out faster, to have researchers willing to share data, so we can address the other part of the speed of it?
Yeah, I think that one way to do it would be to require it of grantees. If you are going to receive this funding to build some sort of tech anything, we would expect that you would then be able to make this open source and be able to have other people access your code. And then I think also not, but explicitly requiring a dissemination plan that isn't peer-reviewed journal articles. Like, I know that we're still getting all these, I'm reading them, but like Facebook interventions are now being published, but they were done like 10 years ago. And so I think that explicitly asking grantees to think through other ways to disseminate, not only to other academic partners, but to the wider audience who might be also creating new products, would be really important.
And I like to marry fields. Brian might be somebody, Mustansky might be somebody good to talk to. So his Keep It Up that Seth mentioned today, its current iteration is actually an implementation science trial where he's actually asking agencies to pick up the intervention and they go through a process of capacitation, et cetera. And again, I think there's this notion of the scale up isn't just we make it and we release it into the market. I think we need to bring it back to the real world, right? Like technology is here to augment reality, not to replace it. And so as we're thinking about apps, and I mean, over lunch, I was telling Liz, like, I don't care to have a EBI on the CDC because as soon as Get Connected shows that it works, I'm breaking it apart and making the code available. And Tech Transfer has already kind of warned me not to do that at my institution, but they have no control over it because we built it and we wrote the grant as an open source intervention. And so those are the things that I want, like if the report actually changes agency behavior, which we are monitoring, then I want to give that code then to the health departments, and they can start monitoring their grantees and improving them and helping them think about things in different ways than just percent screened in this quarter, right?
A remarkable afternoon. Thank you very much.